Hi, everyone. My name is Anna Shah. I am one of the neurologists at the Rocky Mountain MS Center at the University of Colorado. And today we're going to talk about the symptomatic management of MS. So diving right into it, let's start talking about fatigue. So fatigue is one of the most common symptoms that we hear about in our patients with MS and has been described in up to 85% of patients. And now this can be an acute phenomena or a chronic phenomena. One of my favorite analogies to think about when we're thinking about fatigue or why MS patients may get fatigued is thinking about it as a tank of gas analogy. If we said, gosh, every single person has a tank of gas that's similar to a pickup truck, and our MS patients are still driving a pickup truck, but have a tank of gas that's similar to maybe a Mini Cooper, they're expected to do the same amount of tasks with a much smaller gas reserve. And that might be one of the reasons we can explain fatigue so well in our patients, is knowing that their pathways within the nervous system are affected and not able to optimally complete tasks that are needed to be completed. So where does the PCP play a role in the management of fatigue or in the evaluation of fatigue? One of the things that will be a common theme throughout this presentation is MS patients are privy to every other pathology that they can get, and they don't get a get out of jail card just because they have MS, unfortunately. So with fatigue, thinking about ruling out other causes like hypothyroidism, sleep apnea, medication side effects, which is probably a significant contributor to fatigue, are really important. We also know our patients with fatigue may need work accommodations through FMLA forms. For example, if they're patients that feel like their fatigue worsens in the setting of heat, they might need work accommodations that says, hey, I might need to limit time outside, or I might need to work in air conditioning if air conditioning is not provided. Treatment for fatigue, or really lifestyle modifications have been shown to have the best outcomes. This includes a regular aerobic exercise regimen. At least 30 minutes of aerobic activity 3 to 5 times a week has been shown to be most helpful for fatigue. Now, this might be a combination of helping with weight loss, which intrinsically will help with fatigue as fat tissue tends to be inflammatory. It might be because we're helping bolster neurologic connections between different parts of the brain and spine. It might also be some combination of release of endorphins that's helping with that fatigue if part of the fatigue is related to mood disturbances. But nonetheless, development of a regular exercise regimen is going to be critical for the management of fatigue. There are medications that we use for the treatment of fatigue. These can vary from amantadine, which is an old antiviral agent used for the flu. Modafinil or Provigil can sometimes be used for fatigue in MS patients. And then sometimes we will also use medicines like Adderall for the treatment of fatigue in MS patients, but we tend to save those after we have made sure it's not something else. Now, heat sensitivity, again, a really common symptom that our patients with MS report. And sometimes they don't quite report it, but know that they feel much worse when taking a hot shower, or when it's summertime, they tend to just feel a lot more sluggish. This is not specific for MS, and I think that is one of the most important things to point out. And this can really happen in any exposure to heat. It can either be weather, it can be environmental, like hot tubs or showers, or things like exercise fevers. And this can worsen other MS symptoms, also known as recrudescence or pseudo flares. Where might the primary care doctor have a role in this? Again, thinking about work accommodations. If, for example, I've had a patient that worked at a car dealership that noticed in the summer when walking outside on the lot, she was having significant difficulty lifting her left leg. So we went ahead and did work accommodations through FMLA that limited her ability or her need to go outside during summer months. What are treatments available for heat sensitivity? The most obvious one might be avoidance of heat, which in some contexts is reasonable, in some contexts is not. What else can we do to help patients? Cooling vests are an option. All MS patients are able to get a free cooling vest through MSAA or the MS Alliance for America. They can also work on hydration, fans, cool clothing, cooling towels are all effective treatments for heat sensitivity. From a mental health standpoint, I think this is one of the areas that we as neurologists really rely on primary care doctors, because often primary care doctors will know these patients better than we do, especially when they first present, and are often able to see them with greater frequency than their neurologist can, unfortunately, due to access. So what is mental health and what are those symptoms in our MS patients? We know depression and anxiety are prevalent in up to 50% of patients in some studies, and there is a higher rate of suicidal thoughts. So where does the primary care doctor come in to all of this? Screening for anxiety and depression is incredibly important. And then, of course, medication management. Primary care doctors also serve an essential role as a bridge to therapy or to psychiatry. Treatment options, of course, include therapy and then other pharmacologic agents like SSRIs, SNRIs, or other agents. An important thing to think about here is if we think about hitting as many birds with one stone, so to speak, if we have patients with anxiety and depression, but also have neuropathic pain, we might think about an agent like an SNRI, like duloxetine or venlafaxine, as opposed to just an SSRI. So we might hit multiple symptoms simultaneously. How about spasticity? So what is spasticity? Spasticity is a motor symptom associated with any sort of pathology affecting the brain and spine. This is really manifested as, hey, my muscles are very stiff, very tight. When examining them, you'll often feel that catch when trying to do passive range of motion. And these can also sometimes be accompanied by muscle spasms or muscle cramping. So what role does a primary care doctor play here? I think one of the things that can be incredibly helpful from a spasticity standpoint is the encouragement of a regular stretching regimen. It is quite a bit easier to stretch regularly to help prevent spasticity from getting as bad as it can, rather than only stretching when the spasticity gets bad. So much easier to do preventative care than to try and play catch up. It might be helpful for a patient to see their primary care doctor more frequently, so medication adjustments can be made to antispasmodics. And again, also helpful to see what are the risks versus benefits for this patient with that specific treatment. What are we already talked about frequent stretching. I often will tell my patients stretching for 5 minutes a day, 5 times a day. So when they wake up in the morning, right before or after breakfast, lunch, and dinner, and then 5 minutes before going to bed at night. Physical therapy can be very helpful. We often will use antispasmodics for the treatment of spasticity in MS patients, things like baclofen or tizanidine or Xanaflex. While Flexeril is a good antispasmodic, it is not necessarily the best for MS spasticity. And one word of the wise I may give with antispasmodics and spasticity with MS is often patients that are spastic in a limb also tend to be weaker in that same limb. So we also want to balance treating the spasticity and the painful components of that spasticity with not over-exacerbating the weakness that is underlying. Often our patients will use spasticity similar to a cane or an ambulatory aid to help them get around. And if we over-treat spasticity, they're left with significant weakness and may not actually be as ambulatory or functional as they were previously. Other potential treatment options include more procedural treatments. So this can include baclofen pump, which is really effective for patients that respond well to baclofen, but perhaps can't handle the sedating qualities of baclofen, or Botox injections can also be helpful to prevent contractures. Ambulation can be quite a common presenting symptom or symptom as a whole in our patients with multiple sclerosis. The majority of patients will report some kind of ambulatory difficulty, and the variety with which ambulatory difficulties can be had is really quite diverse. So this can range from weakness to ataxia, patients having difficulty walking because they have sensory loss, difficulty walking because of neuropathic pain, or another common one is motor fatigue, where patients may say, I can walk the first 10 feet, I have to rest, and then I feel like I can walk another 10 feet. Well, our hopes are that with the newer disease-modifying therapies that are more effective at shutting down inflammation, we'll see this with fewer and fewer frequencies, but still maybe too early to tell. Where does a primary care doctor play a role in this? And I think this role is critical. It's really to monitor for, can we use higher impact mobility devices? For example, if a patient is